Now, switching gears to the practice questions on acid-base physiology. So, number one, the nurse is caring for a client with a 3-day history of severe diarrhea. The nurse will monitor this client for signs and symptoms or manifestations of which acid-base imbalance. So go ahead and pause the screen and try your best to answer this question in about 60 seconds or less. Okay, this question is asking the nurse will monitor for which signs and symptoms or manifestations of which acid-base imbalance. For the key problem here, a 3-day history of severe explosive diarrhea. Okay, maybe not explosive, but you get the point. So before looking at the options, always think, if it comes out the acidosis, like diarrhea, then it's metabolic acidosis. Since all the base or bicarb, HCO3, in the intestines goes from the body and into the potty, leaving the body in acidosis. Now let's take a look at our options. Option A, respiratory acidosis. No, this client is not retaining CO2 with that low and slow breathing in respiratory acidosis. Kind of sounding like someone sleeping, right? Now, option B, also incorrect, respiratory alkalosis. The client is not panting like a dog in alkalosis, right? This is typically from hyperventilation, where we're breathing off all that CO2. Now, option C, metabolic acidosis. Yes, as mentioned before, if you poop out your acidosis with diarrhea, then you'll be in metabolic acidosis. And option D is incorrect because metabolic alkalosis, this is typically for vomiting up all that stomach acid. So think metabolic alkalosis. Sounds like you're vomiting, right? Okay, moving on to question 2. What is the underlying pathophysiology for respiratory acidosis in a client with COPD? So again, pause your screen and try your best to answer this question in about 60 seconds. Okay, let's break this question down. The question's asking for the underlying pathophysiology for the key problem here, respiratory acidosis, in a client with COPD. So before looking at the options, always think, what 2 things do you know about COPD and respiratory acidosis? So COPD, that chronic obstructive pulmonary disease, just think chronic destruction of the lungs, specifically inelastic alveoli, from smoking and pollutants. So gas exchange is decreased, retaining more CO2 in COPD, which basically pushes the body into respiratory acidosis from too much carbon dioxide, which I call carbon diacid as a memory trick, because it pushes the body into acidosis. So D would be the most correct here. But let's break down the other options real quick. So option A, an airway obstruction with mucus. Now this is incorrect, since mucus is not the main factor in COPD. So remember, COPD, that chronic obstructive pulmonary disease, is from chronic destruction of the lungs. Now B is incorrect as well. Excessive HCO3 excretion via the kidneys. No. COPD does not have to do with the kidneys, but rather the lungs primarily as the underlying patho. Now, option C is incorrect because hyperventilation and blowing off excess CO2 is a big no. So with COPD, we may have actually increased respiratory rate with pursed lip breathing, but the underlying patho is from destruction of the lungs. So option D is the most correct here, because CO2 retention within elastic alveoli, yes, this is the root cause, or the underlying patho here. So just remember, once again, COPD, that chronic obstructive, is from chronic destruction of the lungs with inelastic alveoli from smoking or pollutants. So again, gas exchange is decreased. Question number 3. How does the body compensate for respiratory acidosis? So again, pause the screen and try your best. Now this question is asking, how does the body compensate or basically find balance. For the key problem, respiratory acidosis. So before looking at the options here, let's break it down. Respiratory acidosis. Too much acid, right? From too much CO2 retention, that carbon dioxide. So the memory trick, just think low and slow breathing puts you in respiratory acidosis, kind of sounding like someone snoring. Retaining too much CO2. That carbon dioxide, which we call carbon diacid, pushing the body into this acidotic state. So what do we need to balance out this high acid? Well, we need bicarb base, of course, that HCO3. So option A, HCO3 retention via the kidneys. Yes, this is correct here. Look for the keywords here, HCO3 retention. So remember, bicarb base is retained in the body to balance out that high acid. Now B, C, and D are incorrect. So B, HCO3 excretion via the kidneys. No, bicarb excretion would actually further increase that acidotic state. Basically, we're not finding balance here for compensation. Now C is incorrect because CO2 retention via the lungs. Remember, CO2, the memory trick, carbon diacid. If the client's retaining even more acid, they're going to be in more respiratory acidosis. So it's actually going to worsen the problem and not find balance. And D, CO2 excretion via the lungs. Oh, this is pretty close, but it's wrong here. So remember, the kidneys will help the lungs when it's out of balance and vice versa. So respiratory acidosis is in the lungs, and it's typically caused by something that will cause the client to sleep, like a sedation. So we expect the kidneys to help out here in option A. Now lastly, question number 4. The nurse is caring for a client with the following ABGs. Oh my gosh, it's an ABG question. Okay, so the pH balance is 7.55, the PaCO2 is 46, and the HCO3 is 34. So the nurse should monitor for which signs and symptoms or manifestations of which electrolyte imbalance. So you know the routine, pause the screen, and you got 60 seconds. Good luck. Okay, so using our marching band suit method. Step number 1 is pH. Remember, it is P for primary, so it comes first. pH is 7.55. So we have a base, basically alkalosis. Now step 2 is to find the match underneath. So PaCO2 is 46 in the acid area, so it's not a base match here. Now bicarb, that HCO3, is a 34. Now this is in the B for base area, so we have our match in alkalosis. Now two bases make the alkalosis match, and the kidneys tell us it's metabolic and not respiratory, since the match is in the kidney area. So we have metabolic alkalosis. Yahoo! Okay, but wait, that's only part of the answer here. So the question is actually asking to monitor for which signs and symptoms or manifestations of which electrolyte imbalance here. Oh, snap! Okay, before you freak out here, just think about the memory trick. Hypo-K, or hypokalemia, that low potassium below 3.5, just think low K and alkalosis. So look for low potassium, and that's why A, B, and D are wrong. So C is the most correct option here, as hypokalemia is for that alkalosis. And just think about it here. The typical cause of metabolic alkalosis is from vomiting, right? With metabolic alkalosis. Sounds like vomiting. So when a client vomits, they vomit up all that acid and electrolytes. Because where fluids flow, electrolytes go. So we would naturally have low potassium. So that's why option C is the most correct. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos. Let's talk let's talk about respiratory versus metabolic acidosis or alkalosis. For metabolic, as mentioned before, acid can be found in the urine from those high hydrogen ions and also in the stomach acids, right? So what happens if the patient vomits out all that stomach acid? Well, what are we left with? Acid or base? Well, base. We're left in alkalosis since we threw up all that acid out of the body and into the potty. Now, what about renal failure? We have broken kidneys, right? So can the kidneys excrete those hydrogen ions via the urine? Well, no. So acid is retained, putting the body into acidosis. And lastly, we know that the intestines hold more base, right? So say the client has diarrhea and they poop out all their base from the body and into the potty. What are we left with? Only acid. So the body goes into acidosis. Okay, now our memory tricks are really fun here, so pay close attention. With metabolic alkalosis, we vomit out all that acid, leaving us in a base or alkalotic state. So just think, alkalosis. It kind of sounds like you're throwing up with alkalosis. And you hold your stomach region, indicating that metabolic area with alkalosis. Now, this is also true with NG tube suctioning, that nasogastric tube. Again, too much acid loss leaves us in a base or alkalotic state. So the key points to write down is vomiting and too much NG tube suctioning is metabolic alkalosis. Okay, now for a little side note specifically for pathophysiology courses. They love to test on this, so please write this down. Hypokalemia, that low potassium below 3.5, think low K for alkalosis. Another big cause that pushes the body into this base state. Now just think, the body hates to be out of balance, right? So it's going to try and balance itself out. This is compensation. So the body compensates for both alkalosis and acidosis mainly through the lungs. The lungs change the alkalinity of the body by allowing more or less carbon dioxide to escape while breathing. So the memory trick again, just think carbon dioxide is carbon diacid, since CO2 pushes the body into this acidotic state. So the body will compensate with slow and shallow respirations to retain more CO2, that carbon dioxide, and get out of this alkalotic base state. Okay, now for metabolic acidosis. We have diarrhea, renal failure, and DKA, that diabetic ketoacidosis. So for diarrhea, you poop out all of your base, right? Which leaves the body in acidosis because only acid's left. So just think, if it comes out of your acidosis, well then you'll be in metabolic acidosis. Or just think, if base comes out of your butt, well then you're only left with acidosis. And in renal failure, you retain too much urine, right? So is urine an acid? Well, yes, high hydrogen ions means high acid. So the memory trick we use, if your kidneys fail, then acid prevails. And lastly, DKA, diabetic ketoacidosis. Even the name includes the word acidosis. So that one's an easy one here. But a little side note for the pathophysiology here. These clients try to compensate with those Kussmaul respirations, that rapid breathing and hyperventilation. This is done to breathe out that acid via that CO2 to try to get into alkalosis. Okay, now hold your horses here. Specifically for pathophysiology tests, there are two more big causes for metabolic acidosis. The key term is lactic acidosis. This acid builds up in the body with shock, that low perfusion, and sepsis, that severe infection. So lactic acid levels get higher with prolonged lack of oxygen and many other factors. But for your exam, just remember the double S's of lactic acidosis. So shock, that severely low blood pressure, resulting in low perfusion or low oxygenation to the organs, and sepsis, that very severe bloodborne infection. So for compensation, How will the body get out of this acid state and into a more alkalotic or base state? Well, it's funny you ask. The lungs breathe faster to blow off all that excess CO2, which I call carbon dioxide. So we see rapid, deep respirations. So please be sure to write that down. Now, when the kidneys are in trouble, the lungs will come to the rescue here, similarly to what happens in DKA with those rapid Kussmaul respirations, to get rid of all that CO2, basically all that carbon dioxide. So just think, the body is panting like a dog to get into alkalosis by breathing all that CO2 out of the body. So once again, the memory tricks, metabolic alkalosis, just think about vomiting and alkalosis. And metabolic acidosis is diarrhea because you poop out from your acidosis. And renal failure. Since the kidneys fail, acid prevails.